And with that, we will have our first speaker come up, Dr. Saranya Sundaram from the Medical University of South Carolina. Her project is Ultrasound Imaging is Sufficient and Axial Imaging is Unnecessary for Patients Undergoing Trans-Carotid Artery Revascularization, with our fair president, Dr. Veeraswamy, as the senior author.
Thank you, Dr. Reddy. I'm Saranya Sundaram from the Medical University of South Carolina, and I'm here to discuss the utility of carotid ultrasound prior to trans-carotid artery revascularization, or TCAR. I have no disclosures. Most of the people in this room probably know what TCAR is. It's fast developed into a novel carotid therapy whose outcomes rival other mainstay carotid therapies. Traditionally, we obtain axial imaging prior to the operating room for operative planning, but in more high-volume TCAR centers, they're starting to use duplex ultrasound only prior to the OR without the use of additional axial imaging. And this begs the question whether the lack of additional axial imaging adds an additional risk to these patients. Our objectives today are to confirm patients who receive carotid duplex ultrasound alone prior to TCAR experienced no significant increase in procedure-related complication, post-operative transient ischemic attack or stroke, all post-operative cardiovascular events, and mortality. We also hope to demonstrate the persistence of similar perioperative outcomes between these groups on long-term follow-up. In order to answer this question, we queried the Vascular Quality Initiative TCAR Surveillance Project Registry between the years of 2016 and 2021. In order to find our specific target population, we excluded for the following criteria, and we ended up with about 3,400 patients total, 682 of whom received only duplex ultrasound prior to TCAR, and 2,736 patients who received additional axial imaging. We applied chi-square, t-test, and Kaplan-Meier analysis to this population. In terms of our two study populations, they were of similar age, BMI, and sex-race distribution, and additionally had similar functional status at baseline. Not surprisingly, there was a slightly higher increased mean creatinine in our ultrasound group, likely due to the self-selection of these patients with worsening renal function for non-contrasted imaging. We also see this in our comorbidities as well, as patients in the axial imaging group had a higher proportion of TIA stroke or coronary artery disease in the past, and likely received axial imaging as a part of their workup and treatment of their diseases. In terms of past surgical history, there was a slightly higher proportion of those in the ultrasound group who had a previous history of a contralateral carotid endarterectomy, ipsilateral carotid artery stent, or contralateral carotid artery stent, likely due to the fact that they were receiving regular surveillance with duplex ultrasound and or have received previous carotid angiography or CTA MRA for treatment of their prior carotid disease. We also saw a slightly higher proportion of those in the axial group on AP2Y inhibitor, likely in the setting of previous carotid stent or previous carotid coronary stent as well, and a higher amount of symptomatic patients in the axial group as well, who likely received axial imaging as a part of their TIA stroke workup. In terms of our procedure-related variables, the only notable difference was there was a slightly increased amount of patients in the ultrasound group who received treatment for common carotid versus internal carotid lesions. And in terms of intraoperative variables, there was a slightly reduced total procedure time in the ultrasound group versus the axial imaging group. But despite these nuances, there was no significant difference in lesion characteristics or operative variables between these two populations. In terms of immediate postoperative outcomes, there was no significant difference in TIA stroke between these two groups. There was also no significant difference in other postoperative complications such as cranial nerve injury, reperfusion syndrome, bleeding, restenosis, pseudoaneurysm, axis complication, or progression of their cardiovascular disease. At long-term follow-up, there was a slightly increased amount of ipsilateral TIA stroke reported in the ultrasound-only group. However, looking at functional status, there was no significant difference of functional status between the two groups at discharge or on long-term follow-up, suggesting little clinical relevance of this increase. On Kaplan-Meier analysis, both groups had virtually similar mortality rates at the end of 2 years from all-cause mortality, as seen in the life tables to the right. Additionally, our analysis was slightly limited by a significant patient dropout between 12 and 18 months, and again at 18 months to 2 years. In conclusion, based on our data, we believe that performing TCAR without additional axial imaging poses no additional risks of immediate postoperative complication, late transient ischemic attack or stroke, all cardiovascular events, or all-cause mortality. And we believe that sole use of carotid duplex ultrasound is a safe and feasible option for operative TCAR planning. There are also several benefits to using duplex over axial imaging, including increased sensitivity to occlusive disease, increased sensitivity to physiologic obstructions, and reduced overall cost to patients. At our own institution, addition of a CTA head and neck can cost up to an additional $1,000. This begs the question whether use of duplex can increase TCAR availability to patients either based on financial equity or their contraindication to either CTA or MRA. And I would like to thank my mentor on this project, Dr. Veeraswamy, and the rest of the MUSC Vascular family for their help and guidance. I'll take any questions at this time.
The paper is now open for questions. Go ahead, sir.
Jim McKenzie, New York. I'm volunteered to join the Old Vascular Surgeons Committee. Two things. I'm a firm believer in duplex ultrasound for carotid endarterectomy. But with new technology, it also comes with new validation and everything else. And what I see is, one, what's the IFU? Because I know I have to get a lot of CTs just to show that I've got 5 centimeters of run-up room for doing a TCAR. But also when I did carotid stenting transfemorally, we got a lot of intracranial views, and I get intracranial views when I'm doing a TCAR to help follow up long-term from that. And then finally, with your lifetime analysis, since it's VQI, it's kind of squeeze my fingers, smile, and okay, you have no events. Do we need to go more and look at MR or something to say really we aren't seeing a difference? Thank you. Great presentation.
Yeah, absolutely. In terms of the limitations of duplex ultrasound for TCAR preoperative planning, some of the duplex protocols have actually been extended at several of these institutions that have employed them to include several different maneuvers to be able to determine some of the IFU criteria, such as the distance from the bifurcation to the sternum at the clavicle and other IFU criteria. And then for your third question, about the limitations of the VQI database. It's well known that unfortunately with the VQI database there hasn't been a lot of long-term outcomes reported, and we definitely do believe that we need to follow this up further. And given that Roadster is continuing as well as this TCAR surveillance project, I think we'll have a lot more data to be able to answer those questions.
Are there items that you think would be prohibitive for use only to look at patients only by ultrasound, particular findings that maybe we need to have to develop a protocol for?
Yes, I think that either previous history of surgery to that area may contraindicate just using a duplex ultrasound preoperatively. Additionally, patients who maybe have not ever received axial imaging previously would likely need additional axial imaging prior to the OR.
And Jim, to your point, they do have basically ultrasound training for your lab that they provide, which can be standardized in terms of looking for the length of the common carotid and so on. So that is sort of available to meet the IFU for the device itself.
What about the intracranial evaluation?
And obviously, no. But for the IFU, for the device itself, there is a standardized protocol that can be incorporated into the vascular lab to make sure those parameters are met. Mark?
Yeah, Mark Hunter from Boston. I think this is a great paper and a great way to start this discussion. I think the one thing that we miss in VQI is, like Ravi just said, if patients have had a previous CAT scan and then you have an ultrasound that shows the stenosis, a lot of times that's enough to be able to plan your TCAR. And I think that in the VQI, you're not going to see that, because I think that the thing is, have they had axial imaging in the last 6 months? Mm-hmm. So if you have a patient that comes in, your ultrasound shows everything, you can look at axial imaging from a year ago, you at least know where everything is in the anatomy. And I think that a lot of people use that. So I think your number's probably lower than you think for people that just had ultrasound alone, because I think a lot of us are still not comfortable with that. But it's something to think about, and maybe this is something that needs to be done on the institutional level so that we can really figure out. But that was a great talk.
Yeah, thank you.
Thank you.